Okay. Okay, so we're running now. So I'm going to talk about, we just need your blue bag. If you have your blue bag?
Oh yeah, I just have it.
Yeah, I just need your OPAs and NPAs at the front. And I have a bag valve mask here. I can walk through. So we're going to go in this station. We're going to try to walk through and explain. I got a lot of clipboards here. How to open the airway. Thank you so much. And I have a bag valve mask, so I don't have to utilize this one. We're just going to talk about how we're going to open the airway, how we're going to, so how we can maintain it to be open with some pieces of plastic, how we can suction the airway, and then lastly, how we can utilize a bag valve mask. Okay. So when we walk up to a patient, typically we walk in the room, and most people look at us as we walk in. And we know when they're looking at us and following us across the room with their eyes, and we say, "Hi, how's it going?" And they say, "Good, I'm having chest pain and shortness of breath," that airway and breathing and circulation are less likely to be an imminent threat to life, if that makes sense, because they are having a conversation. And as we work towards being more ill and more sick as a result of some sort of disease, process, or injury, then we can have alterations in level of consciousness. So people will start, as we are having you assess AVPU, the first alert person. I don't really need to. You can mentally go through, hey, airway's good, breathing, how much distress do they have, circulation, they have a regular pulse, but you're not likely to find anything that needs immediate fixing because they're having a conversation with you. And that means that they have obviously enough blood that's moving around to their brain to keep them awake, and that blood has oxygen on it, or else they also wouldn't be awake. So those airway breathing and circulation things are intact enough for them to have a conversation with you. So as they get sicker, that starts to become more subtle. So now we'll have to yell at them to open their eyes, right? So with any alterations in level of consciousness, you have increased risk of there actually being something that you need to fix with airway breathing or circulation. Then to somebody that is completely unresponsive to painful stimuli, that's somebody that's the most likely to have issues in their airway breathing and circulation. But anyone with an alteration in level of consciousness, so when I say walk in, go level of consciousness ABC, LOC informs ABC in a very big way. If they talk to you right away, then you're unlikely to. So airway breathing circulation turns into me, a mental check, they're talking to me so the airway's clear. Breathing, how much distress are they in? Do they have good chest rise and fall? Does it seem like it's going to, do they seem like they're just teetering on becoming inadequate into respiratory failure? Or are they breathing easy? And this is not difficult. But it's not like I'm not putting a hand on their chest, I'm just judging how much effort they're putting in. In circulation, you feel a pulse once again. So it just changes. Where if we're going to pretend this patient, we walk in, somebody else has called 911 for them, and we find them not to follow me in the room, right? So I know I have to look closely at airway breathing. I'm still going to check the level of consciousness, but I know they're not just alert to my presence. And this isn't that they're having a nap, right? They don't usually call a 911 and say, I'm just going to get a quick 5 minutes in here before you show up. Do you know what I mean? So this means that they do have a decreased level of consciousness. So I'm going to yell at them, say, can you hear me? Can you hear me? Then I'm going to provide some sort of painful stimuli. And let's say this patient here, this gentleman, does not respond at all to painful stimuli. So I have to look really closely at airway. So the first thing that I'm going to look at in the airway is to see, is assess the airway. And the two things that I'm looking for is two things. First, there's a tube. When I'm talking about the tube, I'm talking about the passageway from their nose and mouth down to their vocal cords. So inside, so when we come down, this is oropharynx, right? If we puff through, obviously we don't have a nose up here. The nose would be up here somewhere. But when I'm talking about the tube, the path that comes down here and gets down to the vocal cords. Can you see those little white lines in there? Right. Didn't want you to feel left out. So the vocal cords, that's the beginning of your trachea. On the outside of my throat, that's to this level right here. Okay? So I'm talking about that tube needs to be open. So when Dan wanted to see you, Dave, for some reason. Oh, you talked to him. So when you, when I'm talking, we have to, when we're assessing that airway, it's really talking about the upper airway and making sure that that tube, that path for air to get from the atmosphere into your trachea through your vocal cords is open. So that's one thing. And the other thing that when I want to assess your airway is I need to make sure there's nothing in that tube that I could end up sucking into my lungs. And the most common things, so let's talk about the things that could be in there that are in that tube that shouldn't be. Secretions, spit, maybe vomit, less likely, but spit is the most common one. And you know that when you lay down, we don't naturally just allow secretions to pool. Even when you have a decreased level of consciousness while you're sleeping, you swallow, you manage your secretions. So it's completely abnormal to open somebody's mouth and find excess secretions at the back of the throat. Where are we going to find those secretions? Right? They're going to be at the most gravity-dependent spots. Right? It's going to pool at the bottom. So it's going to be, if they're laying in the prone or supine, then they're going to be right at the most posterior, right at the furthest down back. So it's past your uvula, if you can picture that courage hangy ball, right? So the uvula, it's posterior to that, right? So if we, sometimes I'll see people come in and say, we're going to suction, and they do this, right? You're not suctioning, because we have to get back to where the spit would be, right? It doesn't levitate up. There's not that much suction coming out of here that you're, it's not like, not quite, but it would be way awesome if it did. It would be so much cooler. So in order for us to see, to be able to know if there's secretions there, we have to be able to visualize that posterior oropharynx. So we actually need to look and see. And so the ways that we can obtain a good view is by using some of these manual airway maneuvers. The manual airway maneuvers also help elevate the tongue off the back of the throat. So let's just jump to manual airway maneuvers. We'll come right back to that spit in just a second. But we get that the spit could be there and we have to see it, or ideally try to see it. So with manual airway maneuvers, all we're trying to do is get the tongue off the back of the throat so we can see. So you know when you're sleeping, I snore, I like not to admit it, my wife reminds me of it. I snored terribly last night, what are you doing? Like, no. But we decrease our level of, I know, I was like, my wife, no matter what I tell her, like, she never snores. So I'm like,
She does.
Hi, honey. So she absolutely does snore sometimes, not as much as I do. So what happens is, I normally don't snore when I'm here talking to you, right? It'd be odd if I, right? It's because my level of consciousness comes down to a certain point. The musculature in my throat relaxes, and my tongue actually moves posterior a little bit when I'm on my back. Usually you don't snore when you're on your side, right? You snore when you're laying flat on your back, typically. But your tongue kind of comes back, and if you can picture that too, all of a sudden your tongue's kind of flopping down and narrowing that airway. So then when I snore, right? And it comes through, and that's really my tongue contributing to that. If you have more adipose tissue in your throat, so people that are morbidly obese have more likelihood of having, as obesity increases, more likelihood of snoring because they have more adipose tissue in their throat. So the more tissue to kind of occlude that airway. So being able to get that tongue off the back of the throat is very important. And the ways that we can do that is two ways. We can extend their head back with a head tilt chin lift. I think that will be helpful. You'll see that in first aid like this. And the other ways that we can do that, and obviously we would not want to do this in somebody that had some risk of a neck injury, right? So if we had risk of a neck injury, we do a jaw thrust. We just put our fingers on their cheekbones, lift their jaw up. This guy's fairly rigid. My jaw will fly right out very easily. It doesn't take a lot of pressure. This guy's kind of, I don't know, feels like 15 pounds if you can. There's quite a bit of elasticity here. Some of you have a hard time because your jaw, unless you relax, my jaw will actually come out and sublux, partly come out of joint. In order to come out, it has to come. My mouth opens a bit and it comes down. If you can see that. I know. You're like, I can't do it. And some people will have more movement than others. We'll talk about that later. But why would that jaw thrust? What would that do to my tongue? What is moving your jaw? Because your tongue is attached to your jaw. So if we pull your jaw up, then your tongue comes with it, right? And what you can do also is you can combine those two, that head tilt chin lift and that jaw thrust. We can end up turning their head back and pull like that. And that's probably what lots of people will do, that you'll see lots of people do, is the combination of those maneuvers. Another thing that you will see done by some clinicians more comfortably than others is lifting up their tongue and their jaw with their thumb. Now, anytime you stick your fingers in somebody's mouth, you run the risk of getting bit. And some paramedics will cringe. I'll get comments on YouTube that say, "Don't ever stick your fingers in people's mouths. I was bit once." What I would recommend, I can tell you what I do, is I'll gently touch their eyelashes, and if they don't blink, then I feel comfortable. So I want you to try that. So you're going to close your eyes. No, to your neighbor, not yourself. To your neighbor, somebody close your eyes. Okay, close your eyes, and then touch their eyelids and see if they cannot blink. Do you see how you get this massive blink response? Did you see hers? Okay, close your eyes. See how she blinks? Now, yours is more exaggerated, but close your eyes. I don't think I'm blinking. She's not doing that. Well, part of this is probably because you're anticipating. But you see how your eyelids are twitchy? I can see them because I'm scared. Yeah. So if your twitchy eyelids, I don't stick mouths in. Oh, now, if you weren't anticipating it and you're closing your eyes and sometimes you're like, right? Totally blink. It's like this big exaggerate. Well, it's called a corneal reflex, okay? And I've not experienced myself, I've not experienced somebody that didn't blink when I didn't tell them, "Hi, I'm going to touch your eyelids." Okay? And then I feel comfortable. And this is obviously somebody that doesn't respond to painful stimuli. I could lay on the floor and totally fake, and you could give me a sternal rub and a knock. But if you touch my eyelids, I'll blink. Okay? So, and it's the people that would be psychiatrically ill, right? This is mentally ill patients that like bite you willfully, right? That they come up, but most are not trying to bite you. Okay? So I touch corneal reflex. Some will choose not to stick fingers in mouths at all. I will encourage you to watch the anesthesiologists and the other people around the hospital when they're managing airways in people that aren't fully sedated and aren't paralyzed and can still. They'll just, if somebody's completely unresponsive, they might grab and lift up and to be able to see. If you're uncomfortable with that, they're your fingers. I let you choose to do with what you want. I just find I can get a better use of this. Okay? So I'll pull up, and I can't wait for my feedback from my YouTube fans. But I'm just telling you what I do and what others around that I've seen in our region will do. I know, we could have got feedback in the moment. Okay, so when I open that airway, right, and if I see any, there's two possibilities. I see the posterior oropharynx. I see behind the courage hanging ball, the uvula. Did you not call it that as kids? No? I don't know. We used to assess. It was assessed that my amount of courage was judged by the size of my uvula, which I was like, what? How did this become a thing? Anyhow, courage hanging ball. My subdivision. A lot of different sizes? There is different size uvulas. Okay. So, anyways, another time. Moving on. So we're going to have to, sometimes when you open up fully, I was like, what am I hearing? I thought something was boiling. So when I assess sometimes I won't see because their tongue is large and their mouth is small. I won't see. And what that means is that I'll need to suction anyways, right? Because I don't know if there's secretion. So if I have somebody altered level conscious, open their mouth, I can't see what I'm seeing, then I'm going to grab the suction to be able to just suction and make sure there is no secretion. And this is something that commonly in emergency medicine is not done. Remember that somebody can have an intact gag reflex. They might gag on this. We'll talk about that here in a moment. If I forget, remind me. But but anytime somebody has secretions pooling in the posterior airway, then they're at risk of sucking that into their lungs. And your lungs are supposed to be sterile. What is in your mouth is not sterile, right? So we want to very much make sure that blood and secretions and anything that was in the mouth does not go into the lungs. So we don't want them to pull that down into the lungs and then get an infection there. They end up with pneumonia as a result of that. Okay? You hear aspiration pneumonia. That means that they end up sucking something in their lungs they should not have. Air is the only thing that's supposed to go down into your lungs, not other stuff. Just in case you're wondering, because normally, like, this is highly innervated. Normally, you defend like of your body, the most highly innervated portion of your body of nerves is in your throat, trying to protect your airway. Like, you're really wired not to let stuff into your lungs because you know that that's bad for you. And if you do inhale something, then you cough and sputter and cough and sputter, right? So it doesn't end up not as likely to get down as far. Whereas in somebody unconscious, you're not going to do that. We're just going to suck it down. It's going to get bagged around in their lungs. Then it's going to grow because it's a nice, warm, dark environment. So if I was a bacteria, I'd be like, love this cozy spot. I'm going to pull up this alveoli and take a seat, have babies.
Anyway.
So, the binary fission. Okay, so where the frig are we? So off track. So we're opening the airway, and we're going to try to visualize the posterior oropharynx in anybody that has an altered level of consciousness. If we are able to either see secretions or unable to visualize the posterior oropharynx, then we're going to suction. So that's going to lead us to suctioning. So we've gone over manual airway. The one contraindication is that anybody that we don't want to bend their neck, at risk of injuries, then we don't bend their neck. Okay? Jaw thrust is the manual maneuver of choice. It's not going to get you as good of a view, and it's not going to open the airway as much as if we were able to do jaw thrust and head tiltion. So, to our Shop-Vac. This is very much like a Shop-Vac. They're a little bit more expensive. They run around around $1,500, so they're a little bit more expensive than your Shop-Vac. But that is just all things medical. So with your Shop-Vac, we have, like any other Shop-Vac, we have a tube, this little piece of rigid plastic on the bottom. I'm just going to finish for the sake of that video. The little piece of rigid plastic, this is called a yanker. You've probably had one in your mouth at the dentist. Okay, same thing. It's got some holes at the bottom. Holes in medical language is called fenestrations. There's a fenestration up here. I don't know. It makes me. I don't know. It makes me sound smarter, doesn't it? My fenestration, rather than the hole up here and the holes down here. So in order to create negative pressure to the tip, you have to cover the big hole here. Okay. So it's a way of turning suction on and off, essentially, to the patient while the vacuum is on, rather than doing it. Right. You just apply suction or don't. Then we have the vacuum hose, so suction tubing is what that will commonly be referred to. In this unit, there's different ones. It's going to come, it comes right through to here. Any vomit or spit would drop down to the bottom. Because this has a gasket on here, it's all sealed in. Air would be continued to suck through, so the air will suck through up into this tube here, where the pump actually is that's creating the vacuum. There is a float here. It's designed like your Shop-Vac to try to keep you from sucking vomit through the pump and destroying this $1,500 vacuum. Don't rely on it. If it gets that full, then we'll have to empty it. Typically, that doesn't. It can happen, but it's not typical when we're suctioning spit. So we just have to empty it and then continue on suctioning. So there is that little float that's supposed to prevent it from going further. It makes sense that this has to seal perfectly in. There's a little tube that leads. There's another little valve to help try to keep you from getting both a filter to help try to prevent any kind of contamination out to the atmosphere, but also one more stopgap for trying to keep vomit out of your thing. Don't get vomit up into this tube. They are an expensive machine. It needs to plug in. So this whole circuit needs to be all continuous with no holes. And how we can check that in the morning when we come on the truck, because I'd like not to figure it out when I go to suction somebody's spit at it or vomit at their airway. We'll talk about spit. Vomit, I'd roll them over first, get whatever I could out, and then suction the remnant out. Is I just kink the hose, turn her on, and see that it creates a nice big negative pressure, right? See this gauge that flows up here? That means, and you'll hear when I let go, right? So it just means that this doesn't have any holes in it. I don't hear any, right? Whereas if this is not plugged in right, and I go like this, right, it's not doing anything. So my container has to be actually no holes in the container. Now, when you're suctioning, you notice that this gauge has that there's different levels. It's like your vacuum at home, that you can turn it on a little bit and create a little bit of suction. You turn it a little bit more. But do you ever notice at home you don't tend to turn it on just a little bit? You're always just turn it all the way on and suck the dirt up, right? And in the oral pharynx, you tend to do the same. Because it's not a closed container, you're not likely to create large negative pressure. When we use suction down into somebody's lungs, that's a closed system, and we can create a lot of negative pressure and cause tissue damage. So in the oral pharynx, we can just turn this on all the way, okay? Now we do want to be cautious that we don't create a huge amount of pressure, negative pressure, okay? And damage the mucosa in the back of the throat. So we can watch this pressure gauge, as you notice, with the when I turn it up, you can watch I can get a little bit of pressure there, right? In adults, ideally I don't want to go over 120 millimeters of negative pressure, but it's hard to do with a yanker. And in kids, you don't want to do 80. But typically that just means don't jam it towards things and let it do that. Can you hear the difference? Right? So don't let it do that. Okay? So when we're going to suction, we'll just say I turned that on. Just so you can hear me when I'm going through. I'm just going to visualize as best I can, and I'm going to insert to the posterior oral pharynx, and I'm going to gently suction back and forth, okay? Until the spit, blood, vomit, whatever's there is gone, okay? Then I can come out. Now your book might refer to not going any further than the depth of the oropharyngeal airway. You're not going to see people typically size for this. They just know that I'm not going to go past the Adam's apple, right? You won't see somebody like this with the yanker, okay? They'll just suction at the posterior oropharynx, and they won't typically measure. Because usually when this happens, we just want to suction it out. We're not trying to measure. We just go, and nice gentle technique. Remember, mucous membranes can bleed easily and easy to cause trauma. So we're just going to suction the same as you would like the back of your throat sectioned out. We don't want to be aggressive because it's easy to scrape the back of your throat and cause damage and swelling and bleeding. So that's suctioning. So indicated anytime there's secretions in the airway or we can't visualize the airway. There's the contraindication, there's no contraindications, it's just doing it right, so not creating too much excessive pressure. So we've done manual airway maneuvers, we've done suctioning, and now we're moving on to, now that we can put some piece of plastic in to help us keep that tube open. So we're still on airway. The first part of the airway that we just did, we visualized, which helped open as well, the airway, the tube, and then we got rid of anything that was in the airway. Now we're going to take advantage of some pieces of plastic to try to keep that tongue off the back of the oral pharynx. Now the first piece of plastic we'll talk about is an oropharyngeal airway. It's just a piece of plastic, it's just a big straw, sized to go in their mouth. Now these are sized, we size from the corner of the mouth, I'll grab one that fits perfect, I'll show on this side. Size from the corner of the mouth down to the earlobe, some folks will say corner of the jaw, I don't care, it's in the neighborhood. And then over here so you can all see here on this side. We'll size it this way, not like this. Okay, so we'll size it like this, not like this. Okay, so put it in the size the way that it's going to go in the patient's mouth. We're going to, so once we find the right one, so you could see that this one would size and be too small for this cat, right? Whereas this one would be probably too large, right?
Okay.
Make sense? And the reason for that is, if we come back to this guy, in an anatomically correct person, mannequin's not anatomically correct, is that when I insert the OPA, where do I want to end it up is just at the base of the tongue. I don't want to be down on top of the epiglottis or on top of the glottic opening, because that's like this epiglottis is flexible. It's cartilage mostly, some soft tissue, and you can push it down on top of it and actually create more obstruction. Okay. We obviously don't want this down past into the esophagus, right? So we want it to size appropriately. So you can see, now what's the problem with the one that's too short? It doesn't go all the way, so some of the tongue can still flip back and cause obstruction. And the one that's too long, obviously we can end up either impeding down onto our epiglottis or just down into way past. Like if I put this in a kid, I'm going to be in their esophagus. That's not helpful. Okay? So we just want it, this is a tongue holder upper is what it is. Okay? It's called an oropharyngeal airway because it's medical and it probably is expensive. No, it's not that expensive. They're not that expensive. So when we're inserting an oropharyngeal airway, we need to find the right size. Now, the yellow is probably perfect for this cat. Green looks a little bit small, but it's in the ballpark. It would probably work. And red is kind of in the ballpark. But yellow's probably the perfect size for this guy. But all of those would probably work. Those three would probably work fine. You need to be in the ballpark. But once we got extreme off, then it would be problematic. Inserting an oropharyngeal airway, the easiest way to do it in an adult is to get by the tongue, is to insert and follow the hard palate. This guy, his teeth are missing, so he's got this metal plate. He doesn't have a hard palate, but you just follow the roof of the mouth back until you meet resistance, then rotate and slide in the rest of the way. And the reason you do that is that's a nice way to get around the tongue. Sometimes if somebody's tongue, they're collapsed, and they have a big tongue and a small mouth, and you insert back, you can meet resistance. The other option is that you can lift that tongue up and then insert. That would work as well. And that's what we do in children. Children, small kids, their roof of their mouth, their palate can be not fully formed, is not, depending on how old they are. So we don't want to cause excessive pressure because we can cause injury there to their hard palate. So we'll use something to lift their tongue up. If not your thumb to lift their tongue up, some sort of a tongue depressor, like a popsicle stick, if you will, a doctor version of a popsicle stick. Insert. So typically in adults, we'll insert down like this, then rotate and go down. Any questions about oropharyngeal?
Does it say over the lips or under the lips?
So either or. Some people will put under the lips just to keep it from popping out. I don't have a preference. I don't care. Often you'll find in real patients it just goes to their teeth. That's where it ends up. In the mannequins, if it's here, I don't care. It's the difference of a few, maybe a centimeter, right? The difference. So this is a tongue holder upper, so it won't make any difference. Okay. So now with the other tongue holder uppers, the ones that come in through your nose. Now, where does your nasal cavity innervate your back of your throat? It comes out behind your uvula. We've been talking about the uvula and the soft palate there. Posterior to that is where your nose joins your oral pharynx. Your nose joins your throat. Your nose joins your oral pharynx. So we're going to be inserting this time down through the nose and ending up down to just at the base of the tongue. So it's going to be sized a little bit longer because it has longer to go. And we're going to measure from the corner of the nose, from the nostril to the earlobe. Okay, so the corner of the nose to the earlobe. Okay, down through. Often, I should say, some clinicians may choose, and more likely that you might have to use a little bit of muco, some lubricant. This is not muco. Mucos are more like, I want to say it's more of a gel. It's not a liquid, and it's a water-based lubricant. This is glycerin. It's not water-based. Well, it's in water, but it doesn't evaporate as readily, so it doesn't gunk up the mannequins. So it's not going to be in a bottle like this. It's going to be a little package like, you know, those travel tubes of toothpaste that you tear off one end. It's exactly what it's going to look like. Okay, so you can tear it off and put a little bit on, just a little bit. We don't need much, just a little tiny bit of lubricant. is all that's required. Now we need to know a couple of things about your nostrils before we shove things into the nose. And the first thing that we need to know is where are we heading with this? So in your nose, where we're the biggest space to insert this to the back of the patient's nasal cavity, their nasal pharynx, is the space between their inferior turbinate. You have these bony shelves that kind of make these 3 C's on the way up in your nose, okay? And the purpose, they humidify and warm air as it comes into your body. And the biggest space is between your hard palate, the base of your nose, and the most inferior turbinates, okay? And how we get in that space is we go straight back, okay? So the base of your nose goes straight back, if not a slight angle inferior, okay? But it's not the tendon. We do not want to shove up like this. We're going to run into more turbinate and find that we don't have any space. So if you want to put anything through somebody's nasal cavity and not just pick their nose with it, it's going to have to be straight in. I say like nailing their head to the bed. I know that's a weird term, but that's the angle, right? Like straight back, okay? Not superior, it's posterior. So you're going to insert. There's one other aspect that we need to be aware of, or 2 other aspects. The septum. The septum between your 2 nostrils is really vascular. It's where most nosebleeds occur. So it makes sense that we don't want to scratch the septum, right? And how we can avoid that is by turning the bevel. So the bevel is like this little shovel tip, okay? So we want to turn the bevel away from the septum so that it doesn't scrape. Can you see how if this is my septum and I'm going in my right nostril, that if I advance down it's going to tend to glance off and not scrape that septum? And there's an area called a Little's area or Kieselbach's plexus that just has lots of vasculature that can bleed easy. And it makes sense that in this patient we're managing their airway, we don't want blood in their airway. Does that make sense? So most people that would be fine, you could insert it anyway. There are certain people that are prone to nosebleeds, and this helps us not cause a nosebleed in that. So we just advance down, and all we're going to do is we're just going to advance straight back and advance down, and we're not going to push through any resistance. We're going to anticipate as we approach the posterior nasal pharynx, there's an area on the posterior aspect where your eustachian tubes from your ears join the back of your nose cavity. And there's a little divot there. And your tube can want to get hung up there. And what we want to do is not push. We want to just wiggle our way through. Okay? So when we get into this divot, rather than get hung up and pushing, we just wiggle our way along. Okay? Also at the base of that there's some lymphatic tissue, your adenoids, very similar tissue to your tonsils, and if they have any infection or enlarged adenoids, that can create more of a thing to get hung up on. So once again, don't push. There has been cases where people have actually managed to push hard enough with tubes into their nose to cause them to go submucosally, actually tunnel underneath the tissue. That's obviously not what we want. We're going to end up with bleeding, but it's soft tissue. So remember how easily it is to scrape the inside of your mouth. Okay, so we want to do the same thing. So we're just going to insert back. If we meet any resistance, we're just going to rotate and advance all the way in. Because these are smaller diameter airway, we're going to always put 2 of them in, just as a rule of, if I see 1 NPA, I want 2 of them. Okay? With the NPA on this side, can you see the natural form? This is going to accommodate it going down towards the patient's base of their tongue, but the problem is the shovel is towards the septum, right? So what I can do in this case is I can start out with the bevel away from the septum and just insert straight back. Don't meet any until I get to the posterior nasal pharynx, or I need a little resistance. And I can just rotate 180 degrees and advance the rest of the way in. If I need any resistance, wiggle to get by, maybe pull back and then wiggle as you're advancing, and wiggle on down past that little divot and those adenoids. Now where this is supposed to come, this guy isn't anatomically correct, and I don't see a really large NPA in here. But the NPAs come out behind the uvula. We can't even see. But it will pass behind the uvula. That's supposed to come out, pass through there, and hold that tongue off the back of the throat. Typically, patients tolerate these better than an oropharyngeal. It creates a little less stimuli. The patient may scrunch up their face as you're shoving it in, but unless they do a gag-like motion, so if there's any kind of like coughing, moving a head motion, if you hear a then stop. Okay? Stop creating the same amount of pressure. Sometimes they'll insert and they'll gag a little bit and it's just a titch bit too long, and you can just pull it out a little bit and then they'll not gag anymore. Okay? But we don't want to cause sustained gag to a patient, is what we're trying to avoid. Who we can't put these, so these are indicated, both of these pieces of plastic are anybody that is not maintaining their tube open themselves. Typically anybody that will take an OPA, we put it in because it just makes it easier to maintain that patency of their airway. And if they won't take an OPA, then we'll often put NPAs in instead. If we're having trouble with an OPA, maybe we'll add some NPAs in addition. So you can have all three and that's more than acceptable. Just more tubes down. You're creating more lanes to your highway to help get air down to the glottic opening, right? The goal is to get air down to here. So we can, as far as contraindications, there's some, there has been some contraindication in your book and on the sheet. It's going to say don't put these into head-injured patients, head trauma. The risk is that maybe the bone that separates, a basal skull fracture that separates their nose cavity from the cranial vault, where your brain lives, could be somehow interrupted, so that you could actually shove a piece of plastic into their brain. Now the idea that you can sneeze into your brain is a bad thing to begin with, right? This has happened, and it's hit some big journals like the New England Journal of Medicine, and everybody got all excited about it. It's an incredibly rare event. The case that was documented that I've seen is about a nasal gastric tube, and it got coiled up in there, and it was bad. The patient was already had a hole between their nose and the brain, and it was bad already. So it's incredibly rare that this happens. But medicine is, for the most part, chosen to say, we're not going to stick things in people's noses if they've had a head injury, unless we can't breathe for them or can't maintain their airway in any other way. Does that make sense? So if you had somebody that was biting together and you were struggling to ventilate them and you weren't getting adequate chest rise and fall, then of course we choose to gently insert NPAs in to try to ventilate them, because we know that they'll die if we don't have adequate minute volume, adequate respiratory rate, and adequate tidal volume. But that would be the only time we'd advance that in, and that's incredibly rare. So as a rule, typically we do not put these in head-injured patients. Okay? We'll call it a relative contraindication. Then we're on to, so that's oropharyngeal, nasopharyngeal airways, we can leave those in. And now we're on to breathing, when we're assessing breathing. Now when we assess breathing, we can look and see, do we have adequate chest rise and fall to assess tidal volume? There's two things when we're assessing breathing, I just said them, that contribute to the amount of air that goes in and out of your lungs in a minute. And that's how often you breathe and the size of your breath. It makes sense that you can't just breathe one time a minute with a normal sized breath and that be enough to keep you alive, right? The same is, you can't breathe 60 times a minute with an itty tiny breath and still stay alive, right? So you need both, the appropriate rate and the appropriate volume. The rate is called respiratory rate. The volume is called tidal volume. The two together are referred to as minute volume. Okay? So if you hear me say minute volume, it means breathing, respiratory rate times, it's just, if I breathe 10 times a minute, and my tidal volume is 500 mils, then it's going to be, I'm going to have a minute volume of 5 liters, of 5,000 mils. You just times the two together. So that's what I'm referring to, respiratory rate and the size of the breath. How often do they breathe, and what size is the breath? So we're going to look, we're going to put, in an unconscious patient, we're going to put a hand on the chest, or maybe watch the abdomen as well, and we're going to assess not only rate, but depth of breath. We'll get used to what normal looks like, but we should see good visible movement of the chest. Okay? We'll also utilize tools like CO2, Untitled CO2, and SpO2 to help guide this. But really at the chest, we should be able to see, do we have good chest rise and fall? If we don't have good chest rise and fall, often what happens is somebody is working towards dying. So breathing normally, what usually happens, you breathe a normal rate, it's usually slow and an adequate depth. Sorry, I'm really into your face, in your personal bubble. Then on to the next, I have small kids, can you, like, I have my son, I'm like, Daddy loves you, we have to respect personal bubbles, you can come here, but you can't crowd your, like, you can't sit on top of your sister, you can't sit on top of your friend. Anyhow, I'm still learning personal bubbles apparently too. So working away from healthy to dying, we breathe at a normal rate and a normal volume. Then I have some sort of injury or illness. What happens? I speed my rate up. I might increase my volume a bit, right? This is like doing wind sprints in the wellness class, right? Or doing box jumps. Then what happens is I start losing, so that's called respiratory distress. It's when I increase my rate and my work of breathing and the effort. Then I start to lose the battle, right? What happens is I start losing the depth of my respiration typically, and my rate will typically stay high. So my breaths shallow way out, and they become inadequate. And then my rate starts, so my volume comes down first, my rate stays high, then rate comes down as well, and then I stop breathing. It's typically how most patients come down. You're going to find variation, but typically. So volume is very important. It's probably the thing that you're going to lose first. So keep a good eye that they have good chest rise and fall, not just rate. Rate will scream at you. Right? If somebody's not breathing or breathing with huge gaps between, right? Somebody breathes a breath every 10 seconds. That's going to look really weird and going to grab your attention. Whereas fast and a little bit more shallow might not to your eyes as quickly freak you out as much, but it's just as big of a problem. Okay? So when we see inadequate minute volume, then we need to provide ventilation for this patient. How we accomplish that is with this bag valve mask. We're going to create positive pressure to squeeze air from here, from their mouth and nose, down into the lungs. Normally we breathe under negative pressure. Our diaphragm sucks down, creates a negative vacuum in our lungs, and sucks air down. So this is a little bit different than how we normally breathe. This is by increasing pressure external and inflating those balloons. So when I actually stick a bag valve mask on somebody's face and squeeze it, the air has two choices of where it's going to go. There's two, what are the two tubes after our mouth and nose? We have our esophagus, or we have our trachea. So our esophagus is like this big tube, it's like a fireman's tube, it's collapsed all the time, right? Whereas your trachea is held open much more like this tube, right? Where it's actually held open. Or like your garden hose, it's held open by these C-shaped cartilage, right? All the way up your throat. You can feel those, right? So it's a tube held open. So it would make sense that it would take less pressure typically to inflate your lungs than to inflate your stomach. Because one tube is collapsed and the other is held open. Now, can you picture that if I have some sort of illness or injury down here, and something is, for a very simple explanation, sitting on your lungs? Let's say they're asthmatic, right? Or they're hyperinflated. There is extra pressure. Let's just visualize it for the time being that something's sitting on their lungs, decreasing compliance. Okay? Or obstructing air from getting in as a result, usually because you have they're hyperinflated, you're not getting air fully in. But somebody's sitting on their lungs. Can you see that I could get to a certain point when the pressure gets so much that I could start sending air down to their belly? What about a hot dog? What if I shove a hot dog right in here, right? Choking, foreign body airway obstruction, right? You walk up, put a bag valve mask on somebody's face, squeeze it. Where's the air going to go? It's going to go somewhere. It's going to go down to the stomach. You're going to get back this kind of moist air coming back. But after a few breaths, if it goes into the stomach, your stomach's not that big, right? So this is about, depends on the manufacturer, it's over a liter, probably upwards of 1,400 mils. I have to go look and see the manufacturer. But your stomach, your stomach is probably is not any larger than this. So you give a couple of deep, big breaths. What happens is that air goes down and kind of gets burped down into past the sphincter that holds your stomach closed, and you build up pressure in there. And then they have this big silent burp, and do you know what? That sphincter builds up pressure behind the stomach, and then it lets that go. And it's not just going to be air that's going to come up, it's going to be vomit that comes up as well, because it's just pressure. So it's going to squeeze, they're laying on the back, air's going to be at the top, vomit's going to be at the bottom, mix of both is going to come up. And it's going to be quiet. They're not going to go, it's just going to be suddenly you have vomit in the back of the airway. Okay? And that's because you've managed to squeeze air down into the stomach rather than into the lungs for whatever reason. So realize, now when I squeeze this, typically I'll see these lungs, this chest rise. That would be another absent piece if I had a hot dog stuck in my throat that I would squeeze, and I wouldn't see as nice of chest rise. It would make sense as I inflate the belly a little bit, I might see a little bit of asymmetrical movement, but don't expect it to be no compliance whatsoever. It'll be have to squeeze harder to get air in, but you can still squeeze air into their stomach. Okay? So does it make sense that when I'm squeezing the bag, typically, I try to do it nice and softly. I try not to apply a lot of pressure to then open up that esophagus to rush it in. Right? Because even with a normal trachea, if I go, right, I can absolutely shoot some air into their lungs and some into their belly. Okay? So we want to have a nice, gentle squeeze. When you normally breathe in, it's kind of over, it's like pouring a glass of, filling a glass up. Sue always uses this example, I'll steal from, but it's like when you breathe in a little faster at first, right? And then you slow down towards the end, right? You kind of pour the glass full at first, kind of aggressively, and you get towards the top of the glass, then you ease off, and then you stop. And that's what we're going to breathe like as much as possible with these patients. So we're going to breathe for them with a nice soft, as far as volume, is the time that we put this volume into their lungs, okay? So nice and soft. The other aspect is that we want to allow for enough time for them to breathe out. Normally, if you breathe in for half a second, then you would typically breathe out over 1.5 seconds. Usually there's a 3-to-1 ratio. Inspiration is 1 part, and then it takes 3 parts for expiration. Obviously those shorten as we increase respiratory, but we're trying to mimic normal respiration with the bag valve mask. So we want to allow for full exhalation. What happens if I don't? What if I just stand here and go? A better picture would be as if I do take something that's a little bit more of a closed system, right? What happens if I increase huge pressure in here because I don't allow for full exhalation, right? So we want to make sure normal respiration, you have an inspiratory phase that lasts for one part, let's say 0.5 of a second. Then expiration, that's 1.5 of a second. And then you have a pause, right? If we normally breathe every 5-6 seconds, we've used half a second here, 1.5 seconds, 2 seconds, then we're going to pause for 3 seconds. If we lose the pause, that means the patient's not fully exhaling all of the air. Does that make sense? So at no point should your patient lose the pause. Okay, so we want to make sure that we have a full pause. So it's very easy to feel here at the head when you're feeling excited to breathe this, to not only create too much pressure, but also to breathe too often for the patient. So often when we're ventilating patients, it'll be a breath every 5 or 6 seconds, so either 12 or 10 breaths per minute. And you're going to have to remember that. So in here, a tool that you will use in here is a metronome, we'll set a metronome to count for you. You hear a noise, you can download a free metronome on your phone, and you're just going to hear it. I'm going to set this one to 12 breaths per minute, it's just 12 beats per minute. So every time I hear a noise, I'm supposed to give a nice, light breath. See how it's longer than you think it's going to be? And when you get excited, I can totally see myself as a young, new paramedic. And I used to do this. And this also really messes up your blood pH. You know, you can't just stand here and hyperventilate. You hyperventilate for 30 seconds. And it drastically, you get dizzy, right? It actually changes your ability for your hemoglobin to drop oxygen off to your brain and other organs, right? because you increase it likes it too much. So, we need to have the proper volume and the proper rate. So in lab, let's watch each other. Let's make sure the nice soft hand's delivering and nice volume. So OPA and NPA, the simple part is making the seal. We'll talk about that. An EC technique, so you can make a C, then you pull your fingers down onto the jaw, like so, and we're going to pull that jaw towards our belt. Make sense? And lift that up. So I tend to use my left hand and use my dominant hand for the bag, and my non-dominant hand for holding the seal. These fingers shouldn't push in on the soft tissue. It should be along that bone. Makes sense. I don't want to be over here pushing in by the trachea, right? So pull up. And if I want to assess and see if I have any leaks around, okay? So I'm going to squeeze like so. Now if I had a leak on this side, I can move my bag over here and apply some pressure down. But you should think of this being pulling the face into the mask rather than pushing the mask into the face. Does that make sense? So pull the face up into the mask. Just like so in the plate. So we're going to let you have a turn at that really quickly. Any questions of big bag valve mask? So we want to mimic normal breathing. So normal volume, just until we see when we see chest rise stop. Then we stop inflating. That's usually about 5 cc's per kilogram. For me, I'm 100 kilograms, so that means about a 500 cc breath. But that means nothing to you with this in your hand. It makes a difference with a ventilator. But with this, we just squeeze gently until we see their chest rise. And when it stops rising, we stop, because we don't want to put pressure down into the belly. And then we give a breath every we'll say every 6 seconds, 5 or 6 seconds, depends on the book you read. Okay. I tend to use 6 seconds. And then we'll look at SpO2 and expired CO2 to make a decision about further changes to this. Okay? So we're going to let you have a turn at this.